So we're live now.
Yes.
All right. Hello, everybody. Thanks for joining us tonight. On Thursday night at 6:30 for Smilow shares, should you know or be screened for lung cancer. We have a great panel tonight. We got Dr. Mike Cohenuram, as well as myself and Dr. Rudolph, who hopefully over the next little bit are just going to educate you a little bit about lung cancer screening, about lung cancer in general, about smoking cessation, and answer any questions you have. And really the goal at the end of this is that you're all subject matter experts when it comes to being screened for lung cancer. And it certainly maybe it doesn't apply to you, but if you have a loved one or a friend, you can certainly go out and educate them and tell them what you learned today. I'm just going to talk a little bit about the folks that are going to be talking to us today. Dr. Mike is a medical oncologist, trained at Mount Sinai. Did his fellowship at the Yale School of Medicine and also did his residency up at Brown. Has multiple awards with the Castle Connolly as a top doctor, as well as in Connecticut's magazine Top Doctor, and currently has his practice in Park Avenue as well as in Fairfield, and sees folks at Bridgeport Hospital. The other panelist that we have is Dr. Rudolph. Dr. Rudolph has been a community pulmonary physician now practicing in Fairfield County for over 30 years. He specializes in the evaluation and treatment of respiratory diseases to include COPD, asthma, and lung cancer. And he does have a special interest actually in nicotine addiction, which I think he's going to talk a little bit about. He went to the medical school at NYU, did his pulmonary critical care fellowship at Albert Einstein Montefiore. So I guess what we'll do is get started. I think one of the things I want to do is, if you can see it, I'm going to open it up and then share my screen. There's a link in your, you cannot start sharing. Hey, Gene, do you mind if I share for a second? There is a link in your, I can't seem to get it right now, but there's a link in your chat box that if you click on it is a story that came out just recently about one of the success stories with lung cancer screening, someone that all of us here treated just last year. And if you can't get the link, let me know and we'll resend it out. So Gene, if you want to go back to sharing your slides. And we'll go, and Dr. Rudolph will start with his, we'll start off with Dr. Rudolph. If you want to unmute yourself, Dan.
Are you able to hear me?
Yes.
Okay. I don't see my visual. Okay. Good evening. The road to lung cancer screening very often starts in the primary care office and the office of a pulmonologist. The taking of a history includes trying to evaluate the degree of risk. That includes how much each individual smokes. Every primary care doctor and pulmonologist spends time in this and tries to evaluate whether patients are at risk or candidates for screening. As most of the medical profession knows, people who smoke a pack a day for 30 years are at risk and are sent for screening. The problem of nicotine addiction is enormous. Most of our patients with a nicotine addiction problem are carefully interviewed and evaluated when they're first seen in our office. The degree of their problem very often lies in their addiction to nicotine, which is a chemical addiction. Many people don't understand this problem well or understand the possible solutions. Screening is obviously one of the more important tools we have in evaluating whether their addiction will lead to medical problems, including chronic lung disease, heart disease, or malignancy. We have a number of tools available to help these patients. That includes pharmacology, medical therapy, and counseling. We have to be very careful when we take the histories to make certain that we get accurate histories of their addiction. Very often it's not that simple. People are not very forthright in giving us accurate information about the degree of their addiction. But if time is spent in the initial visits carefully understanding the severity of the addiction, then proper steps can be taken to try to help and correct and treat their addiction. Recognizing that it's a chemical addiction is the first priority. Referring them to subspecialists to treat the possible complications of their addiction is also critical. In my practice, I found over many years that one of the primary treatments of their addiction include nicotine supplements or medication. It's very difficult to conquer addiction of nicotine without the support of medical therapy. Also, the addition of counseling has been found to be very useful. It's a pleasure to be working with the group of physicians and Smilow to try to treat these patients in a collaborative fashion. The center has offered counseling programs and screening programs that are critical in trying to address this serious problem. In my 30 years of practice, I have to say, over the past couple years, since the development of this program, we've been able to collaborate and focus on the treatment of these patients and refer them to the screening program for lung cancer, which is critical in preventing life-threatening malignancies in our patient population. The cigarette smoking is probably one of the leading preventable causes of death in our community. The risks are enormous. Obviously, the risks of medical issues regarding heart disease, chronic lung disease, which I face in my office, and malignancy, particularly lung cancer, are the most common problems they face. Next slide. This slide just focuses on the problem of nicotine addiction, which is basically the problem where nicotine attaches to a receptor in the brain, causing neurotransmitters or chemicals that lead to a calm sensation, making it very difficult to break this pattern of the cycling pattern that causes people to smoke. Nicotine replacement therapies and medical therapies have been very useful and are critical, as I mentioned, in addressing the problem. Next slide. The reason that we're here tonight is because of the American smokeout. The problem of smoking in this community is enormous. The new problems related to vaping in our adolescent population has grown and has become a serious problem. The American Cancer Society has allowed us to have the opportunity to get together tonight and talk a little bit about this program, this problem, and the programs devoted to address the problem. Community recognition is primarily one of the most important ways that we can focus on this problem and address the severe complications that occur with this addiction. I'll move on to allow my colleagues to speak about the details of the cancer screening program and some of the issues related to lung cancer.
Yeah, that was great. That was really a nice overview of some nicotine addiction and some of the efforts that go on, both in your practice and, throughout the county to help people quit smoking. In your 30 years, what have you noticed has been the most successful that's helped people either, cut back or quit?
My personal experience is that to allow patients to understand that this is a chemical addiction is one of the primary challenges as a healthcare provider. A lot of people don't realize that nicotine addiction is basically a chemical addiction. And if they're able to understand it as a chemical addiction, they're more apt to be able to accept medical treatment, which I think with medications, including Chantix or nicotine supplements, are required to conquer the addiction. It's very difficult, and I haven't seen a lot of people who, quote, go cold turkey and are able to stay away from relapse, which leads to continued smoking. So recognizing it as an addiction, knowing that it's really a chemical problem is one of the things I've learned many years of practice.
No, that's great. I think, Amy put a question in the chat box for you. And for any of the attendees, please use the chat box if you have some questions. We're happy to field them as they come in. She says, do you find that there are a lot of side effects from the medications given to patients that are used to assist with stopping them from smoking?
The nicotine supplements have very few side effects because basically they're delivering nicotine in a different form. That includes gum, lozenges, or transdermal applications of nicotine. So nicotine supplements are unlikely to cause side effects. Unfortunately, the other medications, which include a drug called Wellbutrin, which is basically an antidepressant, can have side effects, and so can Chantix, which is well known for mood disorders. But I find that the rarity of these drug complications is not excluding people from drug trials. I do think everybody who is faced with this addiction should be given the opportunity for a drug trial. And one of the more important things is to follow up, see these patients after they're placed on medications on a monthly basis, not let them go and return a year later, but return in a monthly fashion, reassess their response to medicine and their ability to cut down on cigarettes. Very often, it's a slow process. It occurs over a long period of time, cutting down from 1 pack to a half pack to 5 cigarettes to eliminating cigarettes is the strategy that I very often use when dealing with somebody who's addicted to nicotine and smoking more than a pack a day.
No, that's great. That was a great question, Amy. And then, Dan, just one more question for you. Do you have like a success story that's memorable of someone you were able to, help quit smoking, where and any, recent or, long range success stories that you remember?
It happens. It's funny because people don't usually have a dramatic time where they quit. It's a process. So it occurs over years' time. Unfortunately, the ones I remember are people that are facing illnesses that are caused by nicotine addiction and force them to quit. But I try I usually apply a lot of pressure on the younger patients that I have. And I'd say that of all the patients I have, the most memorable are the adolescents. If I can get an adolescent to stop vaping nicotine and understand the risks of complications or medical problems in the future, then I feel that's the most rewarding type of intervention I have at my disposal. The younger population are the most vulnerable, and my memories are of those patients, and I don't have a lot in my practice because I take care of respiratory diseases, except a young patient who had asthma, who I are able to have quit smoking, and their numbers are the most rewarding experiences I've had.
All right, no, that's great. Thanks a lot, Dan. That was very informative. I think we're going to go on. I'm going to talk a little bit about what lung cancer screening looks like in 2020. My name is Vinny. I'm one of the thoracic surgeons at Yale, and basically covered down at Park Avenue as well as at Bridgeport. I've been affiliated now for just over 2 years. And I'm going to talk a little bit about lung cancer screening in 2020. Gene, I'm going to try and take over if I can. If you can not share, I'm going to see if I can do this time. Yeah. Can you guys see my screen? Gene, can you see the screen?
Yes.
All right, great. So we're going to talk about lung cancer screening in 2020. I'm just going to talk a little bit about some local health statistics, the efficacy of lung cancer screening now versus back in the 70s and 80s. And really, what's important to you. Some basic things like, how to read a chest x-ray. Is a chest x-ray helpful for lung cancer screening? How to read a chest CT. Talk a little bit about the metric system. It's funny, just yesterday I saw a patient with a 2-centimeter nodule, and she said, well, how big is 2 centimeters? And the risks and benefits, to you with regards to screening. And what you can see here, this is the cancer statistics for 2010 for the state of Connecticut. And at least in the state of Connecticut, lung cancer is the 3rd leading cause of newly diagnosed cancers, you can see here, and is the most lethal. It accounts for over 25% of deaths in 2010 from cancer. And what's interesting is, prostate cancer and breast cancer are the 1st and 2nd leading cause of newly diagnosed cancers, and there's a robust screening program in place for both of those organs. But one of the reasons why is because, lung cancer is a silent disease. It's often found in more advanced stages. And up until just recently, there hasn't been an effective screening tool to identify patients, typically at an earlier stage. And basically this is a kind of a pie chart just to demonstrate some of the volume with regards to the multiple large control trials that have been done. You can see here that in the American trial, the National Lung Cancer Trial that was done just a little over a decade ago, there were over 53,000 patients. And that showed that lung cancer screening with a CAT scan has a significant impact in mortality, a 20% benefit. There's another trial in Europe that was just recently published actually this year. We had some preliminary data the year or two prior, and that was over 15,000 patients that again showed that lung cancer screening with a CAT scan, a low dose CAT scan, can reduce mortality. And when we compare lung cancer screening, low dose chest CT to other known health screens that you're familiar with and you probably may have had, the number needed to screen with regards to low dose chest CT is to prevent 1 death is about 320. When you look at mammography for breast cancer screening, the number needed to screen to prevent one death ranges in terms of the literature anywhere from 780 to 2,000. And colonoscopy for colon cancer screening, the number needed to screen to prevent one death is about 1,250. So what you can see is, you know, it's comparable with regards to some of the other screening systems that we have in place, which is great news, actually. You know, when we look at the state of cancer, lung cancer in 2020, particularly in the state of Connecticut, you know, 4 out of 49 can wind up getting surgery. 19 out of 49 can be picked up by screening. And the survival, and, you know, I think Dr. Mike's going to talk about that a little bit with some of the, you know, treatment options that have been really far advanced now recently. And then when we come down to what you need to know, it's really important that some of the things I talked about in the past couple of slides is content, you know, but it's really just, it's not as important, you know, what that content is, it's how it's delivered so that you can understand it, figure out how it applies to you to see whether or not low dose, a CAT scan for you or one of your loved ones is something that you may want to undergo. And I think one of the biggest things that I'd like to drive home is that when we look at lung cancer risk, it's really driven by two factors. One is smoking, and another one is your age. And what you can see is that if you look at people that, if you look at pack years here, as the number of cigarettes you smoke goes up, your risk, your 6-year lung cancer risk significantly goes up, as well as your age goes up, your lung cancer risk goes up. So age and smoking status are really the two things that impact things. We can't do much about age, but like Dan talked about, smoking status and working to decrease that can certainly be helpful. Chest x-ray versus CAT scan. You know, here on the left, you can see that this is what a chest x-ray looks like. It's basically a single beam of light that gets shined through. And what we rely on when we look at a CAT scan is just shadows. You can see that the detail is not as good as it is with regards to the CAT scan to the right. And I think the biggest thing that I'm going to try and drive home is if you wind up in the ER, you know, or go to your doctor and get a chest x-ray, whether you had flu-like symptoms, that's not good enough to try and detect or, you know, screen for lung cancer. It's really the CAT scan that is shown to be beneficial. And the way we look at a CAT scan, and I'll talk about this in a little bit, is it's, again, multiple rays of light, beams that get shined through, not just one, and it gets reconfigured to create a little bit more of a dimensional representation of your body and the organs in your chest. And the way we look at it is it's like you're lying on your back and we're standing at your feet and you're being sliced kind of like a loaf of bread, and we can see a lot of the different structures, and I'll talk about that shortly. An x-ray certainly does give us a lot of information. You know, you can see here from the cartoon that we can see your heart. We can see some of the blood vessels coming off your heart. We can see your airway. We can see your bones. We can also see your spine, as well as some of the contents in your abdomen. So it does provide some helpful information, but it's still, in today's day and age, it's not a screening test for lung cancer. You know, this happens to be an x-ray that shows that this person has a 2-centimeter nodule. And I kind of picked this so that we can talk a little bit about the metric system so that you can, you know, have in your brain a way to reconfigure that, because a lot of you have access to my chart and you might read some of these studies that talk about either a 5-millimeter nodule or a 2-centimeter nodule. And, you know, the way I kind of like to explain it is a 5-millimeter nodule is about the size of the eraser on a pencil. A 10-millimeter or 1-centimeter nodule is about the size of a Cheerio. 2-centimeter nodule is about the size of a penny, and a 4-centimeter nodule is about the size of a golf ball. And that's kind of how I, put it into reference for folks. Now, when we look at a CAT scan, you can see that there's a lot more detail that we can see. We can see the details of the major vessels that come off the heart. We can see multiple different areas of the lung to include the vasculature, and it really provides us a lot more information. And the studies that I've talked about have shown that, you know, this can benefit you to try and detect lung cancer at an earlier stage. This is just an example that, or just to show that the chest CT is an effective screening test, and this person has a small nodule on the left lung. Who's eligible for screening? You know, Smilow is committed to an integrated network throughout the system with regards to lung cancer screening, and has a multidisciplinary, comprehensive, you know, team to include the people on this panel. You know, Dan and Mike. You know, we actually meet frequently to kind of talk about the lung cancer screening in Fairfield County. And the people that benefit are adults between the ages of 55 and 80. If you have a 30-pack year smoking history, and the way we talk about what a pack year is, if you smoke a pack a day for a year, that's 1 pack year. So if you smoke a pack a day for 30 years, that's 30 pack years. There's 20 cigarettes in a pack. So if you smoke 10 cigarettes a day or half a pack, it'd take you about 60 years to have a 30-pack year history. You have to either be a current smoker or someone who's quit smoking within the past 15 years, have no symptoms, and, you know, be in a somewhat decent health to be able to tolerate either surgery or some sort of oncologic treatment. And you can see the link there in case you need access to that. So what are the risks? I'm just going to talk a little bit about what a false positive is. That's identifying a lesion that's not a cancer. You know, when you scan from the very bottom of the neck to the top of the abdomen, and, you know, you can sometimes identify a lesion that you've had maybe for your entire life that's not cancer. It's a lesion that's really not a threat to you. Radiation harm, I'm going to review a little bit in the next slide because I know that comes up a lot. There's all the procedure risk, which is if you do have a lesion and we work to interrogate that lesion or find out what it is, you know, there is a risk of a biopsy or surgery, and that risk is much less than 1%. It's a fraction of 1%. Because we're scanning from the neck to the abdomen, there's something called incidental findings. What that means is even though we're looking for lung cancer, the chest CT also looks at your thyroid. It looks at a little bit of your abdomen, your adrenal glands. It looks at your bones. And sometimes we might find something that not necessarily, you know, one of us would be able to help you with, but you may need to see either an ENT surgeon or an ENT doctor or someone to just review that finding. A thyroid nodule happens to be, you know, a common lesion that we identify. The radiation risk, the radiation exposure from a low-dose CAT scan is less than 1. This is abbreviated for millisieverts. It's just the way we measure the radiation. For comparison, the background radiation in New York City is about 3 millisieverts. And, you know, the way I like to explain it is people that work in the airline industry, if you take a flight from New York to California and back, you've been exposed to more radiation at that altitude than getting a low-dose chest CT. So the radiation harm is very low. Now, benefit versus risk, how do we weigh that? Those large studies kind of work to, you know, put that into, quantify that for us. So I already talked about the number needed to screen is 320. When we looked at those complications that I talked about, the number needed to harm, the number of people that you needed to screen to, you know, cause harm to an individual is 10 times, about 3,815. So the benefit certainly favors, you know, obtaining a CAT scan, you know, if you're in that eligibility criteria. And just some of the main points, the eligibility criteria, again, are adults 55 to 80. It's a 30-pack year smoking history, current smoker, or if you quit in the past 15 years, no signs or symptoms of lung cancer, and in good enough health to undergo some sort of treatment. What you can expect if you have a discussion with your primary care doctor is to expect a visit going over those risks and benefits that we talked about so you can ask questions, and that there'll be a team of experts that will be involved in your care. the lung cancer screening, or what Smilow is committed to, is that it's really not just the CT. It is a multidisciplinary approach above and beyond that CAT scan, with regards to your care. And then I'll kind of stop sharing and see if there's been any questions in the chat box, or if anybody has any questions. And then, Gene, if you want to turn it over to Mike, we'll turn it over. So hold on a second. Karen asked a question, why don't you screen until age 55? And that's really a good question. What we have found is, in order to demonstrate a benefit, you have to identify those high-risk patients. And because we know that age and smoking status are the two biggest risk factors, when they did those studies, they certainly did. There have been some studies that looked at if you can go to 50 or if you can go to 45. And it turns out that at least right now, below 55, the number needed to screen would be much higher. And there's not necessarily a mortality benefit for people underneath that age. So that's why we don't screen people under 55. And that's really a great question. I don't know if Dan wants to talk a little bit about that, because I'm sure, Dan, I'm sure you get a lot of questions about that in your practice.
Honestly, I individualize treatment for different patients. I know there's criteria for screening, but my personal feeling is that there are some high-risk patients in the younger patient population, particularly those who are working in factories exposed to other irritants or toxins that might amplify the risk. So I look at each individual patient and decide if they are a candidate for screening based on not only the number of cigarettes, but the other environmental risks that they might have. Certain patient populations are also at higher risks, which we have to make certain that we recognize. Patients with family histories, unusual family histories of malignancies, even if they aren't meeting the full criteria, should be considered for screening. So although there are criteria for screening, I try to broaden the criteria for each individual patient.
No, I think that's a great point. I mean, I think if you look at, where lung cancer screening is in 2020 versus even just 40 years ago, we've learned a lot. And I think that your point about taking into factor other risk factors as well as exposures and family history is certainly something that is being looked at, and it may very well be that I think that's a valid point without a doubt. Are there any other? Yeah, go ahead.
The only other concern I have is that although we've set up criteria for screening, we're still not meeting the criteria in the community. It is known that only about 5 or 10%, maybe less, of patients who really should be screened for lung cancer are getting screened. So one of our challenges going forward as physicians and the community is to try to promote screening to both the primary care providers and the patients themselves. That's why forums like this are so important, to try to educate the community, the physicians, including the physicians, and the critical need for screening going forward.
No, it's valid points. I think we got some other questions. This is great. Appreciate people using the chat box. Tom asks, is there current screening criteria for vaping or a formula for tobacco and vaping to calculate pack years? I have to say, I don't know how vaping calculates into pack years. Mike, Dan, do you guys know?
No, vaping's only been around for 5 years, so we haven't really we haven't been able to quantitate the risk of that type of exposure, although other types of lung diseases are known to occur in the patients that are vaping. But in terms of lung malignancies, it hasn't been around long enough to really determine that risk.
Yeah, and I think that Martina has a two-part question. I'll take the first one, and then Mike, I'm going to have you take the second one. how often should a person be screened? You know, right now, the recommendation is to do it every year if you're in that eligibility criteria. That has something that's going to continue to evolve because those studies did 5 annual screenings. You know, they didn't wind up following those people with screenings longer than 5 years. So we're still, you know, looking into what the ideal timeline is for how often. But right now, the United States Preventative Task Force recommends annually. So Mike, I don't know what your thoughts are when you talk to your folks about how fast does lung cancer grow and how big should it be detected with regards to growth? I mean, how do you, I mean, it's hard to explain. I mean, how do you think about growth for lung cancer?
I think it's so different. I mean, some lung cancers are very slow growing and creepy crawly. And they may have been around for years and largely stay contained. And other cancers can grow incredibly quickly. Obviously, I think screening has more utility for slow-growing cancers because things won't necessarily change in a 12-month interval, and you won't necessarily see the spread that you can sometimes see. But there's really an entire spectrum of its behavior.
Yeah, no, I agree. The growth kinetics can vary. With regards to how big should it be to be detected, the CAT scan can, you know, get down to, you know, millimeter-sized lesions. So it actually can be, you know, somewhat small. And that's one of the advantages of the screening. And what it's shown in those trials is it really identifies people in the earlier stage, at stage 1 and stage 2. And at least when you look at those studies, you saw the stage 4 more advanced cancers actually decrease to detect it earlier. So I'm going to turn it over to you now, Mike. Mike's going to talk a little bit now. Gene, you want to share the slides or?
Actually, I decided not to use any slides because I think ultimately, really the goal of screening is to stay away from me. So I think really the slides that I created probably are not really germane if we screen and we do this successfully. You know, Vinny, you brought up the fact that we have made unbelievable strides in lung cancer care, and that's true. I mean, when we look back, the cure rates and the long-term survival have, you know, changed tremendously in a positive direction, and it's for 2 reasons. One is we have much better treatments, but the other is through screening efforts, hopefully we're detecting this disease at much earlier stages. And really the goal of screening is to catch it at an early stage where the cancer can be cured. And hopefully if that is the case, you will not meet someone like me and the chemotherapy that I have. Again, if the hope is that you catch it in stage 1 or stage 2, stage 1 would be, basically a solid ball in the tissue of the lung. Stage 2 is if it's gone to lymph nodes and what they call the hilum, which is where the lung attaches to the center of the chest. But both of those can be cured, stage 1 and stage 2 definitely with surgery. But stage 1, we will sometimes find a patient either is not physically able or does not want to go through surgery. And we actually have non-surgical options, including what they call stereotactic body radiotherapy, which is basically a very short accelerated course of radiation where the beams kind of come in from all these different angles and basically burn the tumor. I don't know that it's quite as good as surgery, but some of the data actually shows that the same rates of cure at 5 years. It does risk not fully staging people because when Dr. Mase does surgery, he also looks at all the lymph nodes, and really then we make sure that we're not missing what may be slightly more advanced disease. But stereotactic radiosurgery is definitely an option. And then there's even what they call ablative techniques. The interventional radiologists, and we have some excellent physicians in the area, can actually insert a wand into the tumor, and they can either create an ice ball and freeze the tumor, or they can microwave it. And those, again, are two ways that we can cure early stage cancers in patients where surgery is not an option. There are times where patients are caught early enough through screening, but it has still spread to the lymph nodes, where Dr. Mase or Dr. Rudolph may send a patient to me, because if the cancer has spread to the lymph nodes, the thought is that while the patient is probably cured no matter what, there is a high enough risk of the cancer further spreading and coming back later on that we can give them a very short course of chemotherapy just over a period of a couple of months. And it's like using weed killer. If you imagine just 1 or 2 cancer cells that are floating out there, and if we're able to kill them before they grow into big enough collection that they can start to cause problems, we further add to the rate of cure that Dr. Mase has already given them. Again, the whole point of this is to prevent or at least decrease the chance that the cancer has progressed to an advanced enough stage where we can get into some of the newer immune therapies and targeted therapies that have really become such a big part of our arsenal. But I guess, what I would say is, if God forbid the cancer is more advanced, I really never want people to lose hope. There is just so much more than we can do than what we could do several years ago. So I always feel that I can sit down with a patient and say, no matter what we find, I can guarantee you that we can help you. I think that's about all I have to say from a medical oncology standpoint.
No, I think that's great. That's some helpful insight with regards to where we're at. I appreciate your comments and your perspective. I think we have another question from Natasha. Once the screening is complete and there is a negative result, do you work with the individual who is an active smoker to stop smoking? Absolutely, 100%. I think we all take the approach that, we're going to take care of you, whether you're smoking, whether you're not smoking. And at least, I don't take it as, when you're coming in to talk to me, we're going to spend a long time about, the fact that you need to stop smoking. I think most people know that. We just try and make sure that the resources are there, so that you can, on your journey to either cut back or to quit, that you have all the resources at your disposal. And then you said, I'm thinking of ways to get this messaging into the community. I think that's great. Well, I think, unless there's no other questions, I appreciate everyone's time for joining us tonight. Mike and Dan, thank you very much for your time and wisdom. And I hope you guys have a wonderful Thursday evening.
Thank you, Vin.
Thank you, Vinny. And thank you, Jean, for putting this program together.
Welcome.